now recognize the gentleman from Texas, Mr. Crenshaw, for his 5 minutes, and he will be our last witness.
Indiana for making that point. Maybe I'll expound upon it slightly, which is, I agree wholeheartedly. The point of this is not to just get engagement on social media and get a good clip out of it and bash you guys over the head. The goal is to indeed bring back trust into our public health institutions and help you understand the perception of many Americans. Only about 40% believe that our public health institutions are ready for the next pandemic and that they trust them. That's a glaring statistic. We're seeing declining vaccination rates for children. That's a glaring statistic as well. And I would definitely recommend that the overall communication goal should not to be speaking in these absolutist terms, which has long been a problem, especially with people like Dr. Fauci, when he was clearly wrong, when it's clearly a nuanced discussion. And that makes people skeptical, and you get discredited as a result. Dr. Walensky, I want to bring up a very specific example of this. As you know, the CDC's Advisory Committee on Immunization Practices held its annual meeting to review the CDC's immunization schedules last fall. These schedules, child, adolescent, and adult, consist of a list of vaccines that the CDC recommends for individuals based on their age group. Now, historically, they've relied on states have relied on ACIP's recommendations when determining vaccines, what vaccines will be required for schools and childcare settings. Obviously, that makes sense, especially for childhood diseases that are uniquely transmissible in that specific group. And of course, many of these vaccines do mitigate transmission. The question I have is, in October of 2022, the advisory committee broke public health norms by deciding to add the COVID-19 vaccine, including those under emergency use authorization, to the childhood immunization schedule. That includes the bivalent booster shots. Now, obviously, they're not a mandate, but they, of course, are largely followed. So, I mean, how do you view the cost-benefit of scheduling brand new bivalent booster shots for this age group? Considering the children are at very low risk from COVID-19, 75% of children have already caught the virus, and the vaccine is known to do pretty little to prevent transmission in this age group.
I'm really grateful that you asked that question so I can correct the record here so that everybody understands. First of all, we've had 2,000 pediatric deaths from COVID-19. It's the #1 respiratory and infectious killer that was just published last week in JAMA. So less deadly than to an 80-year-old, but still deadly for a pediatric infection. The important thing I think that's really that we need to recognize is the reason that ACIP recommended and CDC put forward getting the COVID-19 vaccine on the pediatric schedule is not, it was only because it was the only way it could be covered in our Vaccines for Children's program. It was the only way that our uninsured children would be able to have access to the vaccines. That was the reason to put it on the schedule. It can't be eligible for a Vaccines for Children's program to be available to the uninsured unless it is on that schedule. That was the reason to put it there. Thank you for allowing me to correct that.
Okay. I want to move to the FDA, and kind of a different subject. And the subject is this. We're going to have a lot more hearings like this, where we need to fix this problem, where we have innovators throughout the United States who want to save people's lives, and the FDA crushes their dreams and crushes their potential. Their investors pull out. They have no chance of getting through the burdensome clinical trial process that the FDA imposes upon them, nor can they even communicate with anyone at the FDA to figure out what they even need to do. It's a glaring problem. To give you a couple examples, just out of the Houston area, scientists at Baylor College of Medicine who spearheaded a low-cost, easy-to-make vaccine, Corbevax, that is already aiding in the global fight against COVID-19, and we can't get it through here. Researchers at Texas A&M Health and University Texas MD Anderson Cancer Center in Houston are testing PUL042. It's an inhaled therapeutic. They can't get that through either. I could go on non-COVID related, very obvious treatments and biomedical devices that they can't even get a call back from the FDA. What are you guys doing to fix this? Because people are dying and not getting treatment they need, while innovators around the country are trying to fix that, and the FDA is stopping them.
I'll say we could always do better, but let me just say I've been on all sides of this fence. I've been an inventor. I've worked on companies. Recently, before my nomination, I've worked in universities. We lead the world in innovation. We lead the world in new companies. We're doing better than any other country. I completely disagree with your characterization of this, but of course, we always could do better.
No, we lead the world in innovation. That's different than saying that our FDA is helping with that.
We lead the world in translating ideas into therapies that are effective for us and for the rest of the world by far. As far as I know, no one in the world disagrees with that
Well,
characterization.
I mean, is the European Medicines Agency, are they just the Wild West? I mean, are they just approving things willy-nilly? Is that how you view them? I mean, why not work with them when they approve something?
I'm good friends with my EMA colleagues, and I've gotten products through the EMA and the FDA. EMA is a great organization. We lead the world in innovation and in
Gentleman's time is
successful
up.
Thank
companies.
you, Chairman, and respectfully request we focus on that particular problem on a different hearing. Thank you.
I suspect we will.